Anne has a lot of experience in this and a lot of acronyms after her name: registered nurse, MSN, APN. So I feel comfortable that she's going to lead us down that path of side effects and symptoms and help us get through it. So Anne, are you ready to take it away?
I'm ready, Kelly. Thank you
There
so
we
much
go.
for that. Thank you so much for that introduction. So again, we're going to just learning how to navigate your journey. Next slide. So there's several members that are needed for a successful journey. So you and your caregiver are on the center of this little picture here, and you have to understand the different roles of your healthcare team. So as you see here, you have your primary care provider, your subspecialist, which could be your cardiologist, your nephrologist, and so on. You have your general hematologist, oncologist, could be your local cancer specialist, and then you have your myeloma specialist that may be involved. And then you have your allied health staff, the medical assistants, and every other support person that will help take care of you. And of course, you have your family, your friends, and your personal support network. And you should understand how they can all help you out during this journey. Next slide. So as the physicians in the previous two presentations mentioned, there are many treatment options for you to consider. And if you look on the right-hand side, we do eventually come to a treatment decision. So how is that decision made? So it's based partly on your healthcare provider's clinical experience. It's also evidence-based, so data from research and clinical trials will help us come to a conclusion. But again, as Dr. Abenar just said, it's also your decision, your preference. There are many options and you have to be involved, you or your caregiver or both, be involved in the decision as to your treatment plan. And all of the drug classes are mentioned here with their common combinations, as we've mentioned before in the previous two presentations. Next slide. So be an empowered patient. I think that's very important. Participate in the discussions and the decisions. Asking for time to consider options, if that's appropriate, should be considered as well. I think understanding your options is very important. Asking the right questions, and also on the outside, going to reliable sources of information. The key word here is reliable. So ask your healthcare team for the appropriate websites. Of course, myeloma.org is one of them, but you want to go to reliable sources of information. And please use caution considering stories of personal experiences. And these may be stories you read about online, in social media. In the past, people would chat in the waiting room. Every person's myeloma is different. So please, take that into consideration. Express your goals, your values, your preferences. Again, that shared decision-making is very important. Arriving at a decision together, you, your caregiver, your family, and your healthcare team. With all the options available for you now, we can make the right decision for treatment, whether it's frontline or first therapy or therapy at the relapse setting. Next slide. So communicating effectively with your whole healthcare team is very important. So on the left, being prepared, writing down your questions and concerns. You might say, well, I'll remember. I've had these two questions that I have to ask my physician or my nurse practitioner. I'll remember, but maybe you won't. So do write them down. Write them down, bring a little piece of paper with you and make sure your questions get addressed. Also, please keep us up to date with your current medications and supplements. You may want to bring in everything or bring a list. And again, not just the prescribed medications. We do want to know what supplements or over-the-counter preparations or herbal things that you're taking. We do want to know. We do want to know about any medical or life changes since your last visit. And medical changes are important, but also life changes that aren't medical are important. Did you have a change in your living situation? Are you now living alone? Did you move? Do you have a financial situation that is of concern? Again, all of these things are important to us. Current symptoms. Has anything changed with how you feel? Please, we can't read your mind, so please let us know. And in the middle, right, speak up. Speak up. Tell us what's going on. Ask your important questions. Understand your treatment plan, okay? And the next steps. You might say, well, okay, I'm willing to do this treatment option. What's going to happen if this happens, if A happens, if B happens, okay? Have a list of who to contact and when. We should absolutely have your emergency contact information, your primary care doctor's information. I think it's important for us to have that information so we can all be part of your team. I think it's also really important to bring a caregiver for another set of ears, right? It's always important to have that extra set of ears and eyes that can hear and see what's been going on during that visit. I do understand with the recent pandemic that there were guidelines with who can come to the office, who couldn't. I think now most offices are allowing you to have one person come during your visit. So it is important to have that person come with you. And it's important when you leave the doctor's office, communicating with other members of your healthcare team, right? Whether it be the pharmacist, your primary care physician, all members of your healthcare team. Taking medications as directed. Very important because a lot of our medications are oral. They're called oral oncolytics. They're chemo or cancer drugs that are taken by pill or capsule form. We can't see you and watch you every day, so it's important to take those medications as directed. And of course, proper follow-up. I can't tell you how many patients I've had who have done extraordinarily well, especially after transplant. They feel great, they don't follow up, and it can definitely be a very challenging and problematic situation if they do relapse without having seen us in a number of months, if not years. So that's important for proper follow-up. Next slide, please. There should be some tools to help you discuss your treatment plan with your healthcare team. I know that the IMF does have a little treatment discussion tool that's available. I think that it's very important to take time to consider your preferences, your goals, your likes and dislikes before an appointment. Okay, so some of the important questions that you want to ask are what can I expect now? What is my expectation now with treatment, how I should feel from the myeloma perspective as well? What can I expect in the future? And definitely having these conversations at many steps along your journey, okay? Obviously at diagnosis, whenever your treatment stops working, many of these treatments, especially in the relapse setting, are until there's evidence of disease progression or some unacceptable side effect that you're not willing to withstand. Whenever you start a new treatment, again, you're having these conversations about what to expect. Whenever there's a change in your life priorities, again, very important to talk to us about that. I mentioned maybe moving or having a death in the family. It's very important for us to know what's going on. And anytime, any question, nothing is too silly, nothing is too unimportant, nothing is too trivial for us to consider if it's important to you. So please have these discussions with us at every time. Next slide, please. So myeloma as a disease state and the treatments we give you both contribute to how you feel. And most of you in the audience can definitely say yes to that. Myeloma cells on the left-hand side of the slide, myeloma cells in excess can cause symptoms in and of itself. Calcium elevation can cause symptoms. Having kidney disease can cause symptoms, anemia, bone pain, fatigue, infection-related issues, and of course, there's a whole myriad of other symptoms. But the treatments that we give you for myeloma kill the myeloma cells, but also can cause a lot of symptoms. Myelosuppression, which means the drop in your blood counts. Peripheral neuropathy, that numbness or tingling or funny sensations in your hands and feet. Diarrhea, fatigue, deep vein thrombosis, the blood clots that can occur. Infection, okay? It could be shingles. It could be an upper respiratory infection like pneumonia. There are lots of symptoms that can occur just from the treatments we give you to make your disease under better control. And all of these contribute to how you feel. So it's the myeloma and the treatments we give you for myeloma. Hopefully we're getting your myeloma under control so some of those symptoms can be lessened. Next slide, please. So what happens if symptoms are not managed effectively? I think this is pretty straightforward. If you have poorly managed symptoms, this can lead to a variety of situations, right? Anxiety, depression. You can become isolated. You don't want to leave the house because you don't feel well. You don't want to be with your family because you don't feel well. It can lead to missed doses. Again, I mentioned a lot of chemo is given as an oral agent. It could lead to missed doses or even missed appointments where you're missing some of your injections or IV infusion related treatments. And of course, if you miss doses, you're going to have reduced treatment efficacy. Folks, drugs do not work unless you take them, right? Or unless you go to the office and get the drugs. They don't work if you're not taking them properly. And of course, all of this can lead to reduced quality of life. And I love what Dr. Avanar said in his previous presentation is we want to treat your myeloma, but we also want you to have an acceptable quality of life. Okay, so that's very important for all of us as your healthcare team. So discussing how you feel with us is important. And if you have to keep a symptom diary, that's great. I know a lot of you on clinical trials, that's almost mandated, right? So you keep this little symptom diary, but even if you're not on a clinical trial, jot down how you feel on a particular day. And we can also determine if how you feel is related to your treatment dosing. There are many options available that we can discuss with you, but we cannot help you if we don't know what's going on. So my favorite is the patient in the exam room who comes in with his wife or her husband and says, you know, when I ask how they feel, they say, I feel great. And then of course you have the caregiver looking around going, wait a minute, no, you don't feel great. Let's tell her how you feel. So we do have to, as the healthcare team, we have to listen to you, but we also like to listen to the caregiver because sometimes we get more information from them, right? Express your priorities. Definitely tell us what's going on. Fatigue is a common concern, but making the right treatment decision is higher priority for most. Okay, but we want to know how is fatigue affecting your quality of life? Is it an intermittent thing that you can handle, or is it an everyday thing that is severely impacting your quality of life? Please let us know this, okay? Sometimes just minor little things we can do with dose adjustments or scheduling changes can circumvent this feeling of profound fatigue. Next slide, please. Steroid side effects and management. And again, I think that most of you in the audience can probably give this lecture better than I can about steroids. We're all familiar with steroids. I think that in the beginning, when I first started working with myeloma and we were giving frontline treatment to patients, I would focus on the chemotherapy end of the drugs, whether it be Revlimid or Velcade or whatever it may be, right? And then I would say, and you're also going to get dexamethasone, and not really talking about the side effects of dexamethasone. And of course, most of the side effects that patients subsequently complained about were related to the steroid dosing. So I think it's important for your healthcare team to really talk to you and educate you and counsel you about these side effects. So what are they? On the left-hand side, lots of side effects, not just physical, but emotional, irritability, mood swings, depression, crying all of a sudden for no reason at all, right? Difficulty sleeping, a lot of insomnia, fatigue, that up and down. You feel great when you get steroids, and then a couple of days later, you might feel like a truck ran you over, right? Really bad fatigue. Increased risk of infections. Very important. These are immunosuppressive agents in and of themselves, okay? Heart disease, high blood pressure, muscle weakness, cramping. So it's a drug that can definitely have long-term effects on your muscles. I mentioned hypertension, water retention, holding on to fluid, having the swollen ankles and stuff like that, blurred vision, early onset of cataracts. You can feel flushed and have a lot of sweating, that red face, the cheeks appear red after you get dexamethasone. A lot of GI side effects, bloating, distension, acid reflux, ulcers, gas, hiccups. There could be weight gain, not just from the fluid retention, but from also the increased appetite, okay? Hair thinning, hair loss, skin rashes, skin thinning, easy bruisability. There's a lot of things that happen with your skin. Increase in blood sugar levels. All of the diabetics out there that had to be put on steroids know that their blood sugars were a little bit higher the day of and the day after, perhaps, when they're taking the steroid dosing. So again, if you are a diabetic, the person who manages your diabetes needs to know that you are diagnosed with myeloma, and you will be getting dosed with steroids as part of your treatment management. So how do we manage steroid side effects? There should be a consistent schedule. Some people have to take their steroids in the morning. They get that alertness, that hyperactivity kind of feeling right away. And then they get fatigued. And some people, there's a delay in that kind of side effect. So for some people, taking steroids at night is more beneficial to them. This is a personal thing, sort of a trial and error. You have to decide what is best for you. Always, please take your steroids with food. Don't take steroids on an empty stomach. Gastritis or that really horrible heartburn and really more serious side effects with your stomach can occur. So please take your take your steroids with food. You can use over-the-counter or prescription medications for stomach discomfort. Again, please let us know, communicate with us. What's going on? Are you having stomach discomfort? Did you try some things over the counter? If they weren't helpful, we may have to intervene and prescribe something for you. And with certain dosing of steroids, typically the higher dose steroids, we do want to also concomitantly give you medications to prevent certain infections. Again, that's based on the steroid dosing. What's really important, folks, is that steroids help kill myeloma cells. They will help the myeloma cells commit suicide. So please do not stop or adjust these steroid doses on your own without discussing it with us. And again, both of the physicians who spoke today talked about not using steroids long-term, or reducing the dose after the initial induction therapy, or changing the schedule perhaps. We do that as well, but please don't do it on your own. Please talk to us about that, okay? Next slide. Fatigue, depression, anxiety, okay? All can affect quality of life and all of your interpersonal relationships. And of course, some sources can include anemia. So that's your low red blood cell count. Pain can make you feel very anxious and very down. Reduced activity, insomnia, not getting a good night's sleep, the treatment toxicities, bone marrow suppression, these are all contributing factors. How do we manage this? It's great to exercise. And I'm not saying you have to, jog your way from New York to Miami, okay? You just have to do something. Walking, yoga. It doesn't have to be a very strenuous exercise regimen, but doing some kind of exercise program with your physician's approval can be most beneficial. Again, getting proper rest, okay? Napping if you have to, taking some drugs to help you with insomnia might be beneficial. Support, social networks, support groups. I think support groups are crucial, right? You might need professional counseling. And some of you may turn to prayer, meditation, spiritual support. Mindfulness-based stress reduction is important. Sometimes we have to resort to medications. They could be short-term. Very important to note that. Massage, aromatherapy, right? Reiki is also something that's used. Sometimes supplements with our approval. Please let us know what supplements you're taking. Some patients who are very anemic may need transfusions. And then effectively managing other symptoms can make you feel better overall. And I do want to point out here on the slide at the bottom, at least 70% of patients experience fatigue. In my clinic, I would say it's close to 100% of patients have some report of some intermittent or profound fatigue, but only 20% tell their provider. Okay, so that's not a good thing. Please let us know about your symptoms, especially if they're not well controlled, or if you're thinking of, self-harm, or just not living the life the way you want to live. We need to know about these symptoms at all times. Next slide, please. Infection prevention and treatments. So a compromised immune function comes from multiple myeloma, as the physicians mentioned. This is a cancer of the immune system, but also from treatment. Treatments can be immunosuppressive. So it's very important to have good personal hygiene. That includes your skin, your mouth, dental care, very important. Environmental control, we're all with this pandemic, we are aware of washing our hands, using Purell, avoiding crowds, avoiding sick people, wearing our mask as appropriate, keeping the social distancing when appropriate. Sometimes we utilize growth factors to bring up your specific white blood cell subset component. We do recommend immunizations, of course, no live vaccines. And folks, the COVID vaccine is not a live vaccine. Sometimes we have to give you medications for control of bacterial or viral infections. There is some new research that shows for patients receiving active myeloma therapy, especially induction therapy, that getting Levaquin daily for 12 weeks helped reduce infection and the sequela from infections. I think that everyone, if there's one good thing that came out of the pandemic, is that everyone has a thermometer at home, which is a good thing. So if you feel unwell or feel warm, take your temperature. Report a fever of more than 100.4 degrees, not 104, 100.4 degrees or greater, or shaking chills even without a fever. If you're dizzy, short of breath, have low blood pressure, we need to know about this. It may be a sign of infection, which could be very serious for all of you. This may warrant a visit to the emergency room if it's off hours, or if you can't get in touch with a healthcare provider. Okay, next slide. Pain prevention and management. We all know that pain can significantly compromise quality of life, and the sources of pain in the myeloma patient population is of course bone disease. Probably number one, neuropathy, that numbness and tingling that can be associated with pain, and certain medical procedures can be painful. So how do we manage pain? Preventing it when possible, bone strengthening agents to decrease fracture risk, antivirals to prevent shingles or reduce the incidence of shingles, sedation before procedures, of course. The intervention depends on the source of the pain. Where is the pain? What's the intensity of the pain? This may include pain medications, some activity, maybe even surgical intervention, radiation therapy. Again, it all depends on the source of the pain. Complementary and alternative medicine can also play a role in pain management. But please, before you take even over-the-counter medications to control pain, you ask and discuss this with your healthcare team. A lot of medications for pain over the counter are cleared by the kidneys, and we don't want you to take these drugs for long periods of time. Again, tell us about any new bone pain or any chronic pain that is not adequately controlled. Next slide. So knowledge is power, and the IMF has many, many resources to help you learn. There are many things out there for you, folks. There's printed material, there are videos, there's a website, there are webinars, there's an e-newsletter, the Myeloma Minute, which I get all the time. These are downloadable resources, but you can also order them to be mailed to you at home. There's myeloma.org is the website. There's also a hotline, an 800 number that you can call to just request these materials. Excellent, excellent resources to help you learn. And this is, folks, one of the reputable websites that I talked about. Okay, next slide. And of course, you're not alone. The IMF is here to help support you. And at this point, I would just open it up for questions or concerns. Thank you, Kelly.
Oh, you're so welcome. That was a great, God, there was a whole bunch of things that came down there I should have wrote down, but the main thing I just pulled out of there was exercise. And, as Ann said, you don't have to run a marathon. Walking from your house to the kitchen, walking from your house to another room, maybe going down and getting the mail if it's not far away.
Yep.
Those little things add up to keep your body moving. You just have to do it somehow. And, when we did that mindful meditation, it was just to give you a chance to breathe. And so often while you're going through these treatments, as my experience of working with patients for so many years, they do forget to breathe. They come in uptight. They're scared. And these are all admirable experiences that they're going through, but you just got to remember to breathe. So, Ann, you nailed that topic. Now we have a question. If anyone would like to take it, Sid, since you haven't been talking for a while, would you like to take that question?
So sure, it was a great presentation, Anne, by the way.
Thank you.
I think the question is, please talk about the newer drug that is being prescribed instead of acyclovir. I think we're talking about the Val-acyclovir. The brand name is the Valtrex. Anybody who is on a proteasome inhibitor like bortezomib or carfilzomib or ixazomib, and actually matters getting even worse with steroid, should be on herpes zoster or shingles prophylaxis. And I think we're talking about either acyclovir or Val-acyclovir. And that's what we definitely would recommend to be on. Even if somebody had Shingrix vaccination, we still put them on acyclovir or Val-acyclovir.
Mm-hmm.
Should they be taking the shingle shot then?
It's a great question.
Is that a tricky one?
That's a tricky question. Many of the patients that already had shingle shots after being on the proteasome inhibitors and steroid and transplant, I have seen breakthrough shingles even after the shingle shot. So yeah, shingle shot definitely would be recommended, but while the patient is on active therapy, I'll recommend being on both.
What's the best pain medication for foot pain and leg cramps? Ann, do you have anything you'd like to add to that?
So leg cramping, it can be related to treatment. I think it's very important to stay well hydrated to help alleviate cramping. Exercise, as we mentioned before, can also help alleviate cramping. It depends on, I mean, if cramping and pain, I mean, sometimes cramping is intermittent. And again, if it's really painful, we do recommend certain pain medications. Again, we don't recommend any of the NSAIDs for long-term use because of its effect on the kidneys. And some patients who are taking these drugs, they're not taking small doses, they're taking very big doses, which we want to avoid. So again, there are medications that we can prescribe for you to help with pain. Tylenol is always a good option. Unless you've been told not to take Tylenol, you can certainly take Tylenol to see if that helps alleviate the pain.
And another question for you, despite the Metamucil brand, lots of water, how best or treatment to deal with constipation issues?
Yes, I think it's very important to stay kind of on top of the bowel regimen. So I always recommend that if patients are having some issues with constipation, to jump on it kind of early. I do recommend a daily stool softener. I do recommend the gentle laxatives. And I do recommend having Miralax or milk of magnesia at home to be taken either every day or every other day. I think it's a very, you have to find out what works for you. So you have to kind of work with these over-the-counter agents to see which is the best combination and recipe for your situation. I think if these agents are not working, it is a phone call to the physician's group, because there are things we can prescribe for you or recommend over the counter. But I would think that you would want to tell us if it's been a long time since you've had a bowel movement. And again, trying to keep on top of this, having a bowel movement at least every other day is preferable.
Rafat, could we collect T cells for storage the same as we do harvesting stem cells?
Oh,
I mean, it is theoretically possible to do it. I mean, I think the logistic of collecting and storing and the cost of that may be prohibitive. I mean, I would say, the best time to collect it is when you're collecting your stem cells, because, when you do it, you collect the stem cells, 1% of the product is only stem cells. The rest is mononuclear cells. So it's rich with T cells. The question, can we, use these cells for, CAR T cells? I mean, I think a lot of hurdles need to be overcome. Can you thaw the cells and stay alive and stay effective? But I think it's possible. I mean, I think we need to investigate that, because I think one of the difficulty nowadays with CAR T cells is that, we taking patients who, unlike the clinical trials, have been heavily pretreated. We're not collecting, enough T cells. So when they're doing the manufacturing, they're requiring a lot more what we call vector to get these cells, produced. So if we can, use less cells and less vector, we can probably get more patients CAR T cells. So I think it's a great question. I think it's very important to be investigated. I don't see why it's not possible, but the question is who's going to pay for it and how long do you store it for?
Correct. We have another question. Go ahead, Sid. Go ahead.
Sometimes in future, there are trials. One of us are going to also open the trial called allo CAR T. The T cells in patients who had received multiple treatment, they themselves are what we call is effete, senescent, and weak. And sometimes they may not be robust to fight the cancers. And that had been a concern. So the research is moving more towards collecting healthy donor T cells, third party, and then genetically snipped some of the antigens so it does not find the recipient's body as foreign and cause some other problems. So eventually it will be off the shelf, very quick turnaround from a healthy volunteer donor. And I think eventually in the future we'll be using more allo CAR T, not only for myeloma, many other cancers. And that would be the answer to having T cells available therapy all the time.
I see. Are there any alternatives to Dex at this time or on the horizon? Feel free to answer that.
I would
there are different
I would hope
steroids.
so.
Go ahead, Anne. I'm
Go
sorry.
ahead.
No, I just wanted to say, I would hope so, but
Mm-hmm.
I'm not familiar with any. I'll leave that to the physicians.
Yeah, I actually like methylprednisone better. It's shorter acting.
Yeah.
So I use it more than I
Methylprednisone.
use dexamethasone. it's still a steroid, but
Yeah.
it's shorter acting, it doesn't stay in the system as long.
See. Now we have a question from a patient here. What type of flu shot should one take who is over 65?
I think the CDC guideline is called a high strength, higher zone, higher dose flu vaccine for patients who are immunocompromised and above the 65. And most of the institutions and pharmacies that offer it, higher strength flu.
Now I have another question that just popped up in the email. Will Medicare usually cover CAR T-cell treatment? Has anyone had experience with this yet?
Well, they kind of cover it, but not adequately. I mean, I think that's, for example, our institution, we have has not been able to offer it to Medicare patient because obviously the cost is quite high, and unless you charge adequately, because there's associated costs. I mean, the CAR T cells is $450,000, but then you get on top of that the hospitalization, the lymphodepletion, to try to get the patient ready to get the CAR T cells, the post CAR T cells follow up if they need certain drugs to manage the side effect. It can be very expensive. So there may be change in Medicare standpoint and reimbursement, but I don't know what your experience in Houston.
So I have used, of course, CAR T on trial, but when Avecma got approved, we had used in Medicare patients also, but this is a discussion that the myeloma physicians need to have the administration of the hospital and come to an agreement. And we had to come to an agreement, and we could use CAR T cells for our patients with multiple myeloma. Unfortunately, majority of our patients with multiple myeloma are elderly, so this is going to be a national issue, and it is being addressed as we speak at that level as well. So hopefully we'll see even better coverage in future.
I'm not presenting this right. I have a regimen of Eylea injections for retina degeneration and take Revlimid for MM. Does Revlimid have any detrimental effects on eyes?
Not that I know of. I personally do not know what's the Eylea injection, but I assume this is for the macular degeneration that there are injections available. But if the injection is done safely and no risk of any bleeding, one thing is you have to be careful when the patients are on Revlimid. We do recommend thromboprophylaxis. So some of the patients are on aspirin, some of the patients are on a stronger blood thinner, especially if somebody already had a history of blood clot. So this has to be divulged and discussed with the ophthalmologist if you are on a blood thinner and getting an eye injection, and that's something that has to be discussed with the ophthalmologist and see how that interacts. Revlimid per se, no, but associated anticoagulation might change the regimen.
Okay, Rafat, you're nodding your head. I have a question here. Please comment further on getting treatment right at first relapse. Would you elaborate?
Well, I mean, again, patients with multiple myeloma, they're going, unfortunately, to relapse. And when you're relapsing, your myeloma protein goes up or your light chain goes up. I wouldn't, jump the gun at the first rise in your myeloma protein. And actually, most clinical trials and most guidelines require you to confirm that there's a rise, consistent rise in the myeloma protein and the light chain. So I would bring the patient a month later to confirm that the light chain and the M protein is really going up. At that time, obviously, we'll decide, okay, now you're relapsing, we try to do workup, sometimes, do a PET scan or a bone marrow to just look at the burden of the disease and decide on the appropriate therapy. But, again, I mean, I think most clinical trials were done based on biochemical relapse, rise in the myeloma protein, rise in the light chain. So you have to, to show that, but not one reading. You have to confirm that. You have to come back in at least a couple of weeks to a month to show that this is not a transient rise, because sometimes you get, for no good reason or understanding, a rise in the myeloma protein, but then it comes back down, so that's, I think, important.
All right, Sid, one final question out to you. We talked about a stem cell transplant being completed and, the stuff you have to go through within that process. The question is, when is a tandem cell transplant recommended? And what are the indicators? Are there simple indicators for that need?
So tandem transplantation basically means we collect enough stem cells for 2 transplantation or even sometimes more, and use the second transplantation right back to back. So we do the first transplantation, patient's counts recovered, within 30 to 40 days, we just go with the next transplantation planned. This is different from the second transplantation, which usually we use when the disease relapses, and then we use the second transplantation. There have been some papers, especially from Europe, where they showed that tandem transplantation does have advantage over a single transplantation. However, subsequent papers have not shown that efficacy. We did a large trial, above 700 patients, called BMTCTN 0702, where we did single transplant followed by Len maintenance, tandem transplant followed by Len maintenance, and transplant followed by consolidation followed by Len maintenance. And at the end of the day, we found there was no difference among the 3 arms. So we say that single transplant followed by Len maintenance is the standard of care, at least in this country, and we are not recommending tandem transplantation for everybody. There have been some papers, especially in chromosomes, high-risk chromosomes, like translocation 414, where there might have been some added advantage of a tandem transplantation that improves the progression-free survival. So I think in general, we do not recommend tandem transplantation, but by case-by-case basis, we can discuss that with the patient, and you should bring it up with your myeloma specialist.
That's excellent. And, you know, we've heard so much about that in the beginning from Arkansas, I believe is where it was coming from, about tandem and these multiple stem cell transplants, which, as you just said, might not show efficacy as other treatments would today. Miko, is that about where we are?
We can probably do a couple more.
All righty. Do you guys see the anonymous attendee question about their remission and so forth?
I think there's a question, is there a pill similar to Kyprolis? Everybody's need is different, but to just simply answer, Kyprolis or carfilzomib is a proteasome inhibitor, and there is a pill called ixazomib or Ninlaro, which is an oral proteasome inhibitor. Whether that would be appropriate for in this particular situation, I would not know, but yes, there is an oral proteasome inhibitor that is available in the market called ixazomib or Ninlaro.
And that would potentially be easier on some patients and not easier on some patients. It's that kind of thing.
Correct.
Yeah, I see. All right. Rafat, do you want to tell us of any important or upcoming trials you're doing at Indiana?
Yeah, again, I mean, I think you heard about the allo CAR T cells. We also interested in, we call it an allo CAR NK, not T. So there's a cells in our body called natural killer cells. And the natural killer cells are important in getting rid of foreign cells like cancer cells. And so there's a trial we're collaborating with a company where we take donor natural killer cells, take their ability of recognizing, the patient's body, but only teach it to kill myeloma cells. So I think that's a very exciting clinical trials we like. The other thing is that we looking at a way to make myeloma cells visible. There's a molecule on myeloma cells called CD28, and CD28 is very important in sort of kind of hiding the myeloma cells from the immune cells. And there's some pill that you can use that will sort of inhibit that expression and make the myeloma cells visible. So we like to combine that with, other myeloma therapy to make it more effective. So, cellular therapy, I think, is incredible. I mean, the responses are incredible. What we need to make sure is that we make it safer, more specific, and lasting. And so that's some of the research we're doing.
Sid, what do you have going on in Houston right now?
Yeah, so allo CAR T was on the table. And then one thing you probably have already noticed that Abecma is now approved. There is another CAR T that is going to be approved, but still the need supersedes the supply. So we still need more trials in the CAR T arena. So we have more auto CAR Ts opening here as well. But more importantly, we are going to also open a bispecific antibody that with or without daratumumab combination. So that is very exciting. Also targeting another, other than BCMA, called GPRC5D, another target on the plasma cells. So those are the trials that we're hoping to open hopefully by end of this year or early next year. They're already through the regulatory process and approved.
That's fantastic. You never leave a stone unturned, Sid. That's for sure when you do your stuff. Hey, Ann, what's going on up there at your place? I know you're working with 2 other doctors there. Is there anything you want to share with what's going on?
We also have many CAR T clinical trials, and we also have the BiTE therapies in clinical trials, lots and lots of clinical trials. And we have a whole research team, as I'm sure that the other physicians do as well. So many clinical trials, accruing actively for patients with myeloma.
Oh, that's great. Well, all of you had such informative presentations today. As you know, I've done this for a long time, and so have you guys, being doctors and nurses, but I really learned some new things today, and that's good for me to go out and share with the patients. We have 4 people of myself that visit 120 some support groups across the country, and by getting this information out, we have more guide, as it were, to excite people as opposed to them being down and out. But what I really want to do here, after thanking everyone, which I just have, is that your feedback is incredibly important to us today. At the end of this meeting, a feedback survey will just pop up right there on your computer. It's not Big Brother, it happens all the time. And you email it shortly, you fill it out quickly and send it right back to us. And that is it. I like everyone that speaks here. I like to hear what you guys think. I share it with them. We do all work together, so please do that. And finally, I'd like to thank our sponsors whose generous support has made this possible. Amgen, Binding Site, Bristol Myers Squibb, GSK, Janssen, Karyopharm, Oncopeptides, and Takeda Oncology. Thank you. All of you have a good Saturday. A lot of good college footballs on if that's what you watch, but go and enjoy your Saturday. Thanks so much,
Kelly.
everyone. Bye-bye.
Bye-bye, Kelly.
Thank you. I have to decide between Texan and Chiefs now. I don't know.
Uh-oh.
Yeah. So anyway. Okay. Thank you.
Bye, guys.